Hello, everyone. My name is Abbi Huddleston, and today I'm going to be representing my colleagues in presenting our research. Our study is called Inequities in Medically Assisted Reproduction, a Scoping Review. According to the CDC, infertility affects 1 in 5 women in the U.S. Historically, research has shown that infertility rates are comparable across races, education levels, and income brackets. The rates at which women seek infertility treatment correlate with similar factors. Infertility treatments are collectively referred to as medically assisted reproduction, or MAR. That includes assisted reproductive technology, or ART, IVF, IUI, and others. Demographic factors such as race, ethnicity, gender, and even sexual orientation can play an important role in whether someone has access to or utilizes healthcare. These factors can be considered healthcare inequities. In the past, research has often focused on how healthcare inequities are related to the prevalence of infertility. In our review, we explored how healthcare inequities interplay with access to infertility treatment. We wanted to identify areas of MAR research regarding healthcare inequities that might be inadequate, so more research can be focused there in the future. We initially searched for articles using Ovid, Embase, and Medline. Studies reporting on MAR inequities in the U.S. between 2016 and 2021 and written in English were included. Specifically, the inequities we investigated were race and ethnicity, sex, gender, LGBTQ+ identity, under-resourced or rural populations, education level, income, and occupational status. These were adapted from the NIH-designated Health Disparities Populations List. Each article's inequity findings were extracted and reported along with their frequencies. As you can see in Figure 1, our searches initially returned over 5,000 articles. After eliminating some duplicates, we carefully screened over 4,000 articles, eliminating some based on our inclusion criteria. We took a closer look at 96 of them and then finally finished with 66 included in our sample. Shown in Table 1, the majority of studies investigated MAR outcomes by race and ethnicity and found that historically marginalized populations had poorer outcomes. LGBTQ+ populations, men, and people from rural or under-resourced areas were less likely to use MAR or seek infertility care. Most studies found positive correlations between MAR access and income and education. The least commonly studied inequities in our sample were sex and/or gender, rural and under-resourced populations, and occupational status. The designs of the included studies can be seen in Figure 2. Figure 3 shows the frequencies of the 3 most commonly investigated inequities over time: race, ethnicity, income, and education. We didn't see any clear correlations by year. The same can be said for Figure 4, which shows the frequency of studies investigating sexual and gender minority inequities since 2016. From the results of our review, it's clear that additional healthcare inequities research regarding MAR is needed in many areas. We decided to discuss a few of these areas further. In our review, the majority of studies evaluated race and ethnicity. We believe a usable system for race and ethnicity documentation is vital for standardization of future research. The Society for Assisted Reproductive Technology, or SART, doesn't currently require race and ethnicity documentation, so this data is missing for a large proportion of patients, 47% of them according to a 2021 study. Other studies have shown inadequate race and ethnicity reporting in clinical trials in general over the last 20 years, which seriously limits data analysis. In regards to the LGBTQ+ community, studies show that these patients experience significant healthcare barriers, worsened by 1, a lack of awareness and sensitivity by providers, and 2, fear of discrimination. One systematic review examining culturally competent infertility care for this group found that many studies in their sample emphasized the need for patient-reported suggestions to improve competency in providers. This calls for increased community-based participatory research to engage and empower these populations. As for sex or gender, the studies in our sample generally focused only on women. One study found that even though men and women have similar infertility rates, male partners don't get evaluated a quarter of the time. When infertile men were evaluated, one study found an imbalanced diagnostic process where male infertility was only based on seminal analysis, whereas female infertility was explored much more broadly. Additionally, coverage for male factor infertility treatment is also largely excluded by healthcare insurance. Overall, our studies show that race, ethnicity, income, and education were the most frequently investigated MAR inequities, while sex or gender, rural and under-resourced populations, and occupational status were the least frequent. We think that future research should be targeted toward 1, standardizing race and ethnicity reporting regarding MAR, 2, the use of community-based participatory research to increase access for LGBTQ+ patients, and 3, increasing access to MAR for men. Thank you for listening. If you have any questions, please feel free to contact me at the email on the screen. Have a great day.